Hi everyone, this is case 5 debrief. So hopefully this cases has been pretty uh, good practices for a critical care patients. Um, I've heard a lot of good things, from you facilitators again this week. So great job on the case, and I just want to sort of cover a few things, especially on the vancomycin pharmacokinetics monitoring, and also trying to make dosing recommendation or decisions in terms of warfarin in the inpatient setting. Hopefully, it was a good practice, good discussions. So let's kind of start off with the anticoagulation first. So some factors to consider when anybody who are on warfarin, either inpatient or outpatients, these are some things that are that can significantly affect the warfarin, interact with the warfarin, can cause changes or fluctuation in INR. So very important to look at the patient overall instead of just looking at the warfarin doses, INR, and that's it sort of thing, right? Look at the protocols as well. I believe that there is a list of factors that you need to consider before you start somebody or trying to make decisions on their initial dosing. Those can apply as well as somebody's on a warfarin, because warfarin pharmacokinetics, pharmacodynamic changes with a lot of the lifestyle habit that the patient have, even diet, right? Activity, metabolism. So a lot of things can really affect your warfarin management. So some of the warfarin factors that you want to, especially for this patients, right, is to look at what previous dosing regimen the patient have. And I believe like a lot of students are taking account in terms of their dosing previously, and look at their INR results today or whenever that you are encountering the patient, and then see and from there you can try to assess in terms of how well the dosing regimen works to make sure that the patient INR is at goal, right? So this patient, he's been getting the warfarin, right, every day, and there's no indication that she's not compliant or not adherent. So you can pretty much assess that, okay, given this patient has been taking their warfarin every day, but the INR is still therapeutics at 1.9, right? So this can tell you something like, okay, then maybe we need to increase their dosing, right? Just because the previous dosing, even though she's been, stable on it, it's not letting her to be at goal INR that she's supposed to be getting. So that's one factors that you consider to make decision in terms of your dosing. Another thing is acute illness. Patients who are critically ill, have acute illness, infections, they tend to have a lower metabolism because the body's trying to make sure, they are tackling whatever acute illness that they're having, right? So metabolism tends to be lower. So the warfarin tends to get exposed more, and that most of the time results in higher INR results. So that's like one thing to kind of think about, right? And then the DDI, in the inpatient setting, the patient's going to be getting a lot of like new medications, especially in the acute illness setting, right? IV medication that they might not have had in the outpatient setting, and then they come to the hospital and they get all this medication, right? Antibiotics, and then kind of look at their medication list as well at home, right? What other medication that can interact with the warfarin or like increase the risk of bleeding, right? So some of this, she's on SSRI, she's on the antiplatelet therapy, right? So those can increase risk for bleeding even on their own. It has some bleeding risk. With the warfarin, it can it can increase further the risk of bleeding. Especially with all of this happening, you risk the patients, with acute illness, so you risk the patients getting high INR, and that further increase your risk for bleeding, right? So a lot of things to kind of consider in that aspect. And then inpatient versus outpatient management is also something that slightly different. The dosing part, you can sort of just give any dosing, right? You don't have to think about tablet sizes just because you're in the inpatient setting. So you have more, variable dosing strengths that you can give for the patient. But outpatients, you have to match it with whatever tablet strength that the patients have, right? So typically you will only provide patients with one tablet strength to prevent confusion, prevent like duplicating, like prevent getting the different doses or like error of dosing. So they were gonna have like just one warfarin tablet strength at home most of the time. And the way you dose it, you have to base it on what tablet strength they have, right? If they have like 5 milligrams at home, then, either you can only give 5 milligrams or 2.5, right? You try not to cut it further to, 1/4 of tablet. You can even do 10 milligrams or even 7.5, right? As long as they can get it in like one whole tablet or like half tablet, that's what we can give the instruction to them. Even like 3 tablets, right? You can go like 5 milligrams increments or like 2.5 milligrams increment for with a 5 milligrams tablet essentially. So that's kind of like the difference with the outpatient and patient. And also in patients, you have the leeway to monitor the INR daily, which is very important that we monitor the INR daily. If it's in the inpatient setting, we have the resources to do that. This is definitely a lab value that you would want, and or like it's a necessary to get it daily instead of something that you just want to kind of monitor once in a week or something like that, especially if they're unstable, or they're not at goal. If they're at goal, like a lot of hospitals still do INR daily just because it doesn't take much to get INR from the patient. You can combine it with the lab draw for like the morning lab, it's not very expensive to get it, it's an outpatient monitoring that patients get, like to make sure that they're on appropriate dosing of warfarin. So it's not something that you have to worry about like, oh, it's going to be expensive for the patient or like going to be invasive for the patient. No, like it's very easy. We can get it with other labs. So in the inpatient setting, a lot of times, if not always, you will see the patients who are on warfarin being check the INR daily essentially. So, and that helps your dosing as well, because in inpatient dosing setting, again, like I mentioned, right, you can give them different dosing based on the INR. So today you might give them 2 milligrams, tomorrow based on the INR, you might give it, 2 milligrams or like 1 milligram. So a lot of it, are very different in terms of how to dose the patients. While our patients, you can't really, monitor the patients daily, right? It's gonna, gonna cause a lot of non-adherence or compliance to INR monitoring if we have patients come to lab every day to just have INR, right? And in the outpatient setting, you typically, don't see changes as much if they are, they don't have like acute illness or anything like acute happening. A lot of times we don't see significant changes too much within a few days. Like typically we'll, if we change the dose of the warfarin or make any adjustment in their lifestyle that can interact with the warfarin, typically we would have them come, in a week or sometimes even longer too, if we don't have that much concern that they're high risk patient where, they might overshoot the INR to like critical value or like, too high of a value or like too low. So in the outpatient setting, like you typically would just adjust a dose and then have them come back in a week or two based on how risky the patients are. So again, a lot of things to consider while patients are on warfarin, either acutely in the patient setting or when they are stable in the outpatient setting. Number two, this is also something that some students have, are confused with or still don't get the concept, but I just want to talk about the role of bridging while patient on warfarin with parenteral anticoagulation, right? This can either be when somebody is first initiated with warfarin, so we know that warfarin won't take effect or like won't get patients to INR until about 5 days to like a week later. So, bridging for some indication, especially if they have like an active clot, right? A lot of times they will bridge it with parenteral anticoagulation. And if they're inpatient, then it will be the most commonly the heparin, the unfractionated heparin, the continuous infusion one, not the sub-Q, because sub-Q is only for prophylaxis. Or the Lovenox, mostly they're used in the outpatient setting, just because, the patient won't be able to do intravenous medication at home, but at least they can do sub-Q with the Lovenox. Um, and another scenario when you might bridge is like when somebody is having high risk for clotting, and then they need to interrupt their warfarin for maybe either procedure or like they have like another high risk activities or some kind of scenarios where they need to be off of warfarin for some time, maybe pregnancy, like for example, right? So you would want them to be bridged with Lovenox as well, especially for the outpatient, right? Um, and like when they resume the warfarin again, this would be considered as initial dosing or like initial um like initiating the warfarin again, resuming the warfarin again. So you need to bridge them because the warfarin wouldn't get you to INR of 2 between the goal until 5 days a week later. So those are some scenarios to do it. And the way you do it, it needs to be a process and a deliberate instruction as well for the patients, right? You don't just give them like, oh yeah, you're just gonna be on the fridge and then you'll be off once the iron is too. But like, how long is it, right? And then how do you monitor? What should the patient expect, right? Or even in the inpatient setting, like how long do we want to continue the IV continuous heparin, right? So a lot of students, I think, mention about getting the iron until 2, so 2 to 3, which is the goal, which is great. But then a lot of protocols will recommend or like will indicate the INR to be 2 consecutive time at goal before they will stop the parental anticoagulations, right? So even if some patients on heparin and warfarin overlapping, and then 3 days later they got INR of 2, a lot of, depending on your hospital protocol, you might not stop the heparin yet because it might ask you for 2 consecutive um, INR at goal, and this is usually separated in 24 hours. So it's not just like, okay, you get INR in the morning and then you get another INR in the afternoon and then you stop the heparin. No, like you have to wait until the next day INR on 2 and then you can stop it. So just kind of understand what bridging role is, and how long you overlap, what's the process on how to do the whole situation until they stop the heparin and then they can be on regular warfarin dosing. And then just one thing I just want students to start having that mindset in mind is knowing why you're recommending something. Again, I've kind of mentioned this previously as well in previous debrief. When you recommend something, you should be knowing why you're recommending that, because people will ask you, patient will ask you, medical, providers will ask you, like, okay, what's the reason or rationales why you're recommending this? If it's, indicated, then you mention like, oh, because they have this and this, and then what kind of outcomes, that are like anticipation that we should be aware of, so we can continue to monitor patients, and when they go to have the outcomes or they don't have the outcomes, we can provide adjustment or monitoring properly, right? So I think one of the questions that one of the facilitator asked is like, why are we giving thiamine or banana back to patients um, have who are consuming alcohol regularly at home, right? um, so a lot, as he mentioned, a lot of students did not know why we are giving thiamine. So, and I believe Dr. Savak and his lectures should be, are mm, giving the rationales or like giving the indications on why of the thiamine in alcohol withdrawal syndrome. So knowing that why, it's very important, because again, in APIs, in practical practice setting, you will be asked why, and you should be curious too, in terms of, when you recommend something, you should be curious, oh, why we're giving this, what outcomes are we expecting, what should we anticipate, how what kind of monitoring we need to do while the patient is on this medications, or like how do I adjust it, if when do I adjust it, sort of thing. So you should be asking a lot of questions when you're recommending something before you can really explain the importance of medications or recommendations. You shouldn't be recommending it. You should be 100% knowing the drugs, knowing what patient should expect or medical team should expect before you recommend it. Otherwise, you don't know if it's going to cause harm for the patient, right? Or if it's going to be effective for the patient. And you are risking the patient not getting an effective treatment if you don't really understand the recommendation or medication you are recommending. All right. And then lastly, for therapeutics, vancomycin trough monitoring. A lot of students are a little bit stuck on this. So review back on your pharmacokinetics lectures. I know it's on the first year, but some hospitals, although like a lot of them now are using AUC, and then you just plug in and out of the numbers in the calculator, very easy. But some hospital are still using trough monitoring. So one day in the API, like if you encounter this kind of hospital, you should know what to do in terms of what calculations, what are the terms, the calculated terms, and what does it mean, how can you calculate it. So this is just kind of like a like the the equation for trough that you should know. Have this in your pocket guide, or like take a picture of it, or take a screenshot of it, have it in your pocket guide in case you need to do trough monitoring one day. These are all the equation that you will need to either do initial dosing, or if you have a levels coming up, then you would plug it in and then just kind of like calculate your trough and calculate your subsequent doses essentially. So for the first one is the volume distribution, right? The factor here is pretty average for normal patient population. It might change. Again, this will depend on your hospital if they do like different volume distribution for different patients populations. It might change if somebody is critically ill, like they're, it might go up and down. But on average, typically we use 0.7. And then you use your actual body weight to calculate the volume distribution. And then this is the elimination rate coefficient, basically trying to get your, how much they are eliminating it or clearing it. Basically, this is what you get if you have levels. If we have the trough, then we can kind of like estimate, like what are the peak that we are using, and the peak you can get it from this equation right here. So you have the trough, and then you have the dose that gets you the trough, and the full distribution we calculate this way, you get a peak. So once that's how you extrapolate the peak from the trough. So once you get the peak, and then you have the trough on the lap, and then you have the time, right? So this is the time from that dose that you're giving to the trough that you got. So typically it will be about like the interval that you're getting, right? So if you're giving, 1750 milligrams Q24, your time would be about 24 hours. But again, this can change because nurse is not going to administer it right at 24 hours, right? Sometimes it can be like just few minutes difference, so you can just use 24 hours, but you have to look at your MAR summary, medication administration summary, and also the timing of the vancomycin level being drawn. Again, it's not going to be right at the minute you ask for it. So you have to take a look at it and then just make sure it's if it's not 24 hours, then you have to really put it there. Like I would say if it's not within like 30 minutes of the interval, like I would use the right interval. So like maybe they draw it 30 minutes before the next dose, and then like they did the 24 hours dosing interval thing, then it will be 23.5 hours, right? Because it's basically 23.5 hours the trough was drawn from the dose administered. And then you like calculate the half-life, pretty simple. You will use the elimination rate constant here, coefficient here. And then this is where you would try to figure out the subsequent doses. Basically, if you look at this, for example, you kind of like pick and choose what kind of dose you want to give, what kind of interval you want to give, right? So in this case, if you do like, for example, if you want to give 750 milligrams for this patient in like Q24 hours, you just plug in your the calculation that you did. So like level is like dose over volume distribution, you calculated already, and then K you calculated, and then T is basically your interval. Um, and you calculate your VD, you calculate your K, you calculate your half life, um, and then uh, you kind of plug in into that levels equation thing with your plant dose. So for example, if you want to do like 1,000 Q12 or something like that, right? You put like 1,000 here. You have your VD, you have your K in here, and then 12 will be here, right? Because you want to try to give it that way. And then once you calculate it, it will give you like the anticipated trough essentially. And if it's between the goal, then you can proceed with that doses. All right. So that's how you do the pharmacokinetics and vancomycin. I know it's not very hard if you know the equation. This is the only thing that's hard, knowing the equations. But once you have the equation, you just plug in the numbers basically, right? All right, so hopefully that's pretty good practice. If you didn't get, through the equations or do it differently, try it out. Make sure that you understand how to use this equation, because sometimes when I did it, because there's so many numbers in here, so many calculations, make sure you get the numbers that you need. And also, if somebody just want to give you some reminders, AUC monitoring, it's easy, but if you have unstable renal function, for some calculation, it's not going to work, right? Imagine, because like if your renal clearance is unstable, every day it's going to be cleared differently. So like every day you might need different doses. Um, so that's why when somebody has thing like unstable renal function, we don't do AUC because most of the time we don't you do AUC because we don't know if we that levels or like that dose is going to be good for the patients, right? AUC monitoring is mostly used if we have stable renal function, where like okay, we can there's not many variable, right, to get to your planned dose. There's not many variable that can change your levels or pharmacokinetics, pharmacodynamics, so that we can use the AUC monitoring. But for for those who are renally unstable, dialysis definitely, like we try not to do AUC so that we can monitor them more properly, because they're going to change every day with their renal clearance. And this patient definitely renal unstable, so trough monitoring will be more appropriate. And besides, you're only given trough, so you won't be able to use the AUC, right? So if you're given something, use that. I heard some students still do the calculation with the AUC, and the doses are not right? Because the patient's already getting like a doses before. So you cannot use the calculator because you don't have peak, you only have trough. So you have to do the trough calculations. And if you do the initial dosing, that's wrong, right? Because it's not an initial dosing. It is a maintenance dosing. Like the patients has been getting vancomycin. The patients, it's not the first time, you are recommending a vancomycin for the patient. So that's why like the using monitoring is not going to work for this patient. All right, moving on to clinical pearls. Some students are recommending DOAC for the alpha thrombus instead of continuing with the warfarin. I would say it's not wrong. But if you look at FDA approval indication, this is important because, some medications are used off-label, even though they're not approved by FDA for certain indications, but, some of them are still used off-label. And this is one of the instances with the DOAC. And again, it's not wrong. There's just not a lot of evidence backing it up. It's not very strong, indication, right? Like there are some studies, trying out DOAC instead of warfarin for alpha thrombus, but again, it's not FDA approved. So if you're recommending it in real practice setting, if there's something happen, you might be liable. So that's just the caveat of it. So if we can use something that's FDA approved and the patient doesn't have any issues with it, I know like there are some concern maybe with this patient being on alcohol, so it can interact with the warfarin, but again, like it can interact with the DOAC too, right? So I mean, again, it's not wrong, but it's just not FDA approved. And if you do have that situation in the real practice setting, just be careful, like make sure that you consult with the medical provider first before recommending changing them to a DOAC, right? Just because we don't know how risky they are of, the thrombus, how risky they are getting worse or like getting aggregated more clotting and stuff like that. We don't have that much evidence that, if we put somebody on with LV thrombus and DOAC, they might not have a recurrent clotting. I think that's the what do you call it, that's the worry, the concern. Like just because all this DOAC doesn't have that much evidence yet, you don't want to put them on DOAC um if not necessary, right? Just because we don't know, that don't have enough data, like how efficacious it is, essentially. Bleeding wise, it's the same with a warfarin. Both of them have bleeding risk. um and another thing is, like, with warfarin, you can kind of monitor more, and if there's not really like a problem with patients having INR monitoring, or like being compliant, then maybe warfarin is still the best way to go for athlete thrombus, essentially. But for other indication like AFib or like VTE, definitely, like, you don't need to be on warfarin. If they're eligible, there's nothing, no contraindication, then definitely the WAC is still preferred for AFib or DVT or VTE. The second one, some students are recommending for the fluid, recommending colloids, albumin instead of just normal saline or D5, which is again not wrong. But a lot of times colloids or albumin can be more expensive than just like, your normal saline bag. So that's why we don't use it. And the reason we don't, even though it's expensive, it hasn't been shown to be more effective fluid than the crystalloid. So that's why for just fluid resuscitation for hypothermia, or like, those patients who are hypotensive, we just use normal saline bag. We typically use albumin colloids if they have some kind of fluid retention problem, and the albumin, the protein and the albumin fluid can help to pull the water from the third spacing into the what do you call it, the circulation. So that's like most of the indication when we use albumin, when they have some kind of fluid retention problem and we need to pull the water out. But otherwise, a lot of resuscitation will do normal saline. Switching medications, PO to IV in patients, I'm definitely, like, some of you guys are starting to getting the concept of it, trying to make sure that they are getting their medication in the inpatient setting appropriately. But make sure you understand again how to use the drugs, right? The IV drugs, and consider appropriateness, right? If the patient is NPO, definitely, you might want to try to have patients to be in the inpatient setting, getting the IV medication if they can't take it to mouth, right? But again, like sometimes NPO can be just medication only, just food only, and then they're okay with like PO medications. But sometimes it's both the food and medication, not by oral as well, and then they have to do IV for every medication. But so just kind of consider that, look into that information in terms of like can they do PO medications? If not, then you might want to convert the PO to IV. Some of the students, but again, like I mentioned, consider appropriateness of switching that to IV, right? Some of the students recommend IV continuous beta blocker to sort of convert them from the home beta blocker to at in the inpatient setting, a small drip. So this patient is hypotensive. She's in shock. I wouldn't restart her antihypertensive, right? It's hypotensive. So you should be restarting it. You're going to cause more harm. It's going to get more hypotensive, especially if you're switching it to IV esmolol. You use IV esmolol for hypertensive crisis. This patient is hypotensive. There shouldn't be a conversion of their beta blocker into like an IV continuous infusion in the inpatient setting. So again, look at the patients. Yes, you want to make sure they're getting the right medication in the inpatient setting as much as possible. Think about the patients too. How do they present, right? If they're hypertensive, there's no reason for you to continue or resume their antihypertensive until they get back to their normal again, and maybe they get hypertensive, then you might start, restarting the antihypertensive medication. But in this case, the patient is hypotensive. Um, and thinking about like the other stuff too, right? This patient is acutely ill. Um, so a lot of times when you're acutely ill and you don't have any problem with circulation, you might get hypertensive, you might get tachycardia, when you're acutely ill. So try to resolve that first. If that doesn't resolve, then still blood pressure still high, then okay, that's an indication to say like, okay, the blood pressure is just high at baseline. It's not because of the other variables, right? And again, just to make sure you don't get patient worsen in the shock by recommending the antihypertensive IV some more, right? So just consider appropriateness, and also like take a look. Don't just convert everything into IV in the inpatient setting. Take a look at their other lab, their presentations. Does this medication need to be restarted while they're in the inpatient in the acute illness setting, right? Um, if the patients skip a dose or like a two, like are they going to get worse in terms of the condition that they're using the medication for? Is it more chronic, or does it need to be administered to the patients acutely right now, while in the inpatient setting? So think of those when you are trying to convert some PO medication from home med to IV in the inpatient, just because oh yeah, they need to be restarted on everything. No, like you have to assess and evaluate the patients for every single medications you're going to restart in the hospital. All right, that's called medication reconciliation, not just collecting data from patients or collecting what kind of home medication list they have, but also assessing if we need to resume it in the hospital. All right, and then there is also confusion, and also some facilitator wants to bring this up about the use of beta blocker in patients using cocaine. If you search into it, like beta blocker use in patients using cocaine, um, some articles were kind of mentioning like you should avoid beta blocker in somebody who's using cocaine, just because it can cause spasm, which can cause a heart attack essentially, or like heart failure. So that's why in the practical setting nowadays, like in the medical setting, if we encounter patients using cocaine, typically, even if they're indicated for the beta blocker for their chronic conditions or heart disease conditions, we typically try to avoid it, just because it can cause more harm than benefit on those patient population. So we would definitely ask the patients to stop using cocaine, go to rehab. We educate them, like, if you keep using cocaine, your heart's, going to get worse. So, and you're not going to be able to be on this medication, beta blocker, right? Has been shown for a lot of heart disease, like your MI, ACS, heart failure, to be mortality beneficial, right, for this patient. So just a lot of education for this patients. I know it's hard for them to just stop using cocaine, especially if they have been using it for a long time, but just a lot of education emphasizing, if they want to get better, they have to stop. And lastly, triple therapy durations. I think a lot of students know about, like using triple therapy. Sometimes it's needed, right, for patients who need to be on anticoagulation, but also need to be on dual antiplatelet. And in this cases, they have STEMI, still like within 12 months. And then they have this LP thrombus that required to be in the anticoagulation. Those three medications are important, right, during this time. But then how about duration, right? How long can we, keep the dual antiplatelet plus the anticoagulations? When can we stop the antiplatelet maybe, right? So a lot of many different articles would, they are doing a lot of studies, right? They're trying to get as little as possible, right? Because if there's harm, right, having both three together with the bleeding risk. But also we want to make sure that we are covering them so that they don't get thrombosis from the stent, or like they don't get another clotting, right, if they're not on the anticoagulation. So a lot of studies definitely coming up to see what's the appropriate durations to be on triple therapy if you have all of this situation, right? So it ranges from like 1 month to 12 months. I think for this case, this is something that we will need to ask the provider. Same like the DOAC, right? There's no black and white answer. Like it's just need to be discussed with the provider to ask them what's their risk of thrombosis versus bleeding, right, for certain patient. And that's not our scope of practice. Those are diagnoses, and that will be determined from the provider. And then we're just giving him some evidence in terms of what are guideline recommendation available, like the durations. And then there are like some studies that recommending for a certain patient population you can do shorter duration versus like 12 have to be 12 months. So all of this need to be discussed, but our role is giving them all the evidences and all the research that we have done previously, that have been done previously, and giving them all the information so that they can make a better decision in terms of like how risky they are if we took off the antiplatelet versus like continuing it. All right, so that's it for case 5 debrief. Hopefully it was a nice case to show you what critical care is. We will have more critical care for next case, and actually the OSCE too. So hopefully you'll get some sense or some visuals in terms of what critical care might look like in the practice setting. All right, have a good July 4th, and we'll see you guys in 2 weeks. Bye-bye.